It may not be, and it may not be.
It may
so
not
in that
be.
case, you can't use it in the way that José is hoping for.
We don't have, the bottom line is we don't have a foolproof surrogate.
Okay, so we mentioned nutritional supplements, right? We've spoken about some pharmacological therapies that we could look at. We've spoken, and included in that were the 3 omega fatty acids,
So those would be nutraceuticals, as we call them. Nutraceuticals.
Right, so the term is nutraceuticals.
Yeah,
right?
it's not a pharmacy.
From a pharmacological perspective, what is available there that we could consider?
Well, I think that there are a number of things that one can consider, but I don't know if we have to consider them. I mean, I think that if you were to call a standard, the one thing that's been shown to increase weight, although it's not lean body mass, is MPA, hydroxyprogesterone acetate. So it increases patients' appetite, but it doesn't increase their muscle. It probably may decrease their muscle. And then you've got a whole range of the cannabinoids, which may be effective or maybe not. But there's one interesting one coming along now. There's actually 2 interesting ones coming along. And the first one is ghrelin. Now, ghrelin is a hormone, as Vickie will tell us, that is secreted by the cells in the stomach in response to hunger. And
Martin favors investigational, and Martin isn't justifiably enthused, I think, by some of the investigational new therapies. And there may be more than one that comes down the pipeline, but back in the land of dealing with patients, I think it's really important to consider a few simple tenets. One of them is someone gets a cancer diagnosis and has metastatic disease. At that time of diagnosis, you might consider taking their weight history and ensuring their status for key nutrients and correcting any correctable cause of altered metabolism or inability to eat. The disease progresses. During progression of that disease, it should be important to keep track of the progression of the nutritional status, the progression of the weight loss for new facets emerging. So someone develops inflammation at a later time.
Can we speak about patients whose disease advanced? Because there are also patients whose disease are cured, right? And the disease comes under control.
That's right. And that's a very separate case from someone whose disease advance cannot ultimately be halted. And there becomes also the question of what to do in the worst part of cancer cachexia, which is at the very end of life when it accelerates suddenly with great rapidity, frightening everybody and causing sometimes a generalized panic for the patient, for the family, and for the physician. And I think from the palliative consultant's viewpoint, it's a very important perception and guidance that we must have about running in with gastrostomy tubes, central venous catheters, aggressive forms of treatment for something that is not tractable to treatment at that time.
What evidence there is to support artificial nutritional supplementation in a patient who would, say, have short months to live? Can you comment on what evidence there is available to support doing that in those patients?
That's a good question. You know, on this point, the clinical practice guidelines for artificial nutritional support are very clear. And that is in Canada and all of its jurisdictions and all of the other countries and jurisdictions that there are. It's regarded as being inappropriate to start artificial nutrition on someone who is expected to die within the next 2 to 3 months because, of course, the burdens and risks of intravenous feeding or for placing a feeding tube far outweigh any potential benefit that the patient may receive from being fed.
Okay, so I do, just something that just came to mind is that we've been speaking primarily about primary cachexia. And I think we can only really call this primary cachexia once we've excluded any of the causes of secondary cachexia, such as oral thrush or inadequate nutritional intake or constipation, or one of those other causes, drugs that may be suppressing appetite or maybe causing a person not wanting to eat, or even a tumor that's sitting in the patient's esophagus and not allowing him to swallow properly. So I think what we're talking now is where there is no other specific cause other than the cancer being in the body that is actually causing the cancer. So before we can cause that, as clinicians, we have to make every effort to exclude that there isn't. And one of the things that I think as a palliative care physician I've become very aware of is the presence of constipation in patients, causing a loss of appetite, causing all the abdominal symptoms like bloating and belching, windiness and pain, and that once you exclude constipation or you treat the constipation, many of those symptoms and signs are relieved, and the patient then follows up with having a bit of a better healthy appetite and a better nutritional intake. So I think those are what I would say are important to exclude before we start talking about primary cachexia.
So Vickie, if I'm hearing this correctly then, in terms of from a nutritional perspective, it's important to act early in the illness trajectory, to get on top of that early from both a nutritional supplementation perspective, good nutritional intake perspective, possibly
possibly exercise,
possibly pharmacologically, but that's still being really investigated, but a multi-pronged approach early, assessing early, but that in most patients who unfortunately go on to experience advancing and progression of the disease, that in the last few months of life, that those are no longer a focus. And if artificial nutrition is not indicated in that setting, what if we have a family or a patient who desperately taking all these nutrients, and you can clearly see that their cachexia is worsening by the day? What advice would we give them? Is to say as well, look, under these circumstances, they may not be useful and they're now more burdensome as you try and take all of these things. Maybe it's time to review that and maybe stop them?
Well, you just gave me 3 good reasons why a palliative consultation may be helpful around these issues. One of them, as Martin said, there's absolutely no excuse for poor pain and symptom management. So if you have meticulous attention to pain and symptom management, then the person can eat. Later on, when the clinical practice guideline says, okay, I shouldn't start artificial nutrition if I believe the person will die within 2 months, and when you turn the page over, it doesn't say how you do that. You need to, a palliative consultant may be able to help you with getting into frame a good notion of the expected survival of that person. And my 3rd reason was that in the very end of life, psychosocial support is crucial, and people and families get beat up about a lot of issues, and one issue they get really beat up about is the intention of family members to feed and make people eat as part of their expression and manifestation of love and caring, in the face of a complete inability of the patient to receive that love in that form. And somebody needs to go in and debrief that and give everybody the opportunity to walk away gracefully.
Maybe as to follow up on that, as you were saying that one of the challenges we face in palliative care is that there's this misperception that palliative care is only about the last few weeks or months of life, and I think we make a very big difference at that time. But it's also about quality of life and symptom management much earlier, even when patients are still receiving cancer treatments to possibly even cure the disease or even control their disease, that there should also be attention paid to quality of life aspect, and so we can also play a role in there. So I think what you're saying in terms of this, the whole illness trajectory and the importance of nutrition right across the trajectory is just as important as well for palliative physicians who are involved in the whole trajectory of the illness. I was wondering if I can ask you one last question, and that is, it's not unusual to see in practice corticosteroids, dexamethasone for example, being used for appetite stimulation, because it's known that people get the munchies when they are on steroids. Steroids are very useful for several indications in managing symptoms, for pain management, spinal cord compression, etc. But in the context of appetite stimulation, what would you say is the role of the corticosteroids?
They work. Some patients will start eating 1,000 calories a day, more than they had done before being given corticosteroids. Problem with it is the side effects of those drugs, which have create it's like a Cushing syndrome. You can't keep that up for more than 30 days.
Also the issue of sustained response. I mean, clinical experience would suggest that the response to steroids is very transient.
So some short period of time.
2 weeks.
Yeah, that's what.
So it's not a good idea to sustain these patients
And of course,
long
because of
term.
the myopathy, they start breaking.
And that's the hitch.
Yeah.
Is the muscle wasting. Corticosteroids cause fantastic muscle wasting. So you can get appetite and eating and sometimes weight gain as a consequence if enough food is ingested, but the muscles will waste away spectacularly during that time. So that kind of treatment should be confined to the very last stages and very short treatment periods.
So if we were to summarize and pick up what we think are the key clinical take-home messages, practical take-home messages from this conversation, what would we say? Assess the nutritional status early and ongoing.
Early nutritional assessment, to take account of previously existing and developing nutritional deficiencies. And trying to look after this problem in context of the whole disease trajectory, which changes as the disease is variously cured or becomes refractory to treatment.
And that there's a lot of research going on at this point in time, and we'll be seeing some interesting.
There's research. We'll be seeing interesting new therapies and more specialized services where specific cases of cancer, cachexia, and malnutrition can be referred, and sources of rehabilitation, both nutritional and physical.
I think Martin's point about the prevention of secondary cachexia is a really important one, and that that ties in very much a palliative care consultation and a search for any remedial causes.
Correct.
So any oral infections, causes of nausea,
Causes of pain,
simple things, pain,
constipation, delirium, all the day-to-day things that can stop a person from eating.
Yeah. Well, thank you very much. I certainly learned a lot here, and I appreciate everyone coming in. And thank you very much.